I want to hand over to Dr. Mercy Korir, who's going to introduce a very able panel and also introduce the discussion today. So over to you, Dr. Korir.
Thank you very much, Mike. A very good morning to you, and thank you very much for joining us this morning as we discuss your health. Now, today we are discussing issues on insurance and provision of healthcare in general in Kenya and the models of insurance that we have. That's from both private insurance and the public insurance, which is NHIF, which covers at least about 20 million Kenyans. Now, spending on healthcare is an expensive affair for many Kenyans. Many have various forms of insurance to afford them health, NHIF being the commonest. This is still, however, not enough for many families. Private insurance covers a fraction of Kenyans, most of which is provided for by the employer. Today, that is the basis of our discussion on your health. So do you have health insurance? Has it helped you? And what you need to know about provision of quality health. Now, in Kenya, as I'd said, about 17% of Kenyans, that's 1 in 5 Kenyans, have health insurance. Now, NHIF is the largest provider with about 6 million principal members, and that covers up to almost 20 million Kenyans. Per family, that's about 3 to 4 people covered per family. Now, in 2013, out-of-pocket healthcare expenditure in Kenya was said to be on the rise, and this was about 61.5 billion Kenya shillings, and out of these, 48.4 billion was in outpatient care only. Now, the providers of outpatient services in Kenya is 58.4% in public health facilities, 17% in private facilities, 13.1% in chemists and pharmacies. This is where most Kenyans go for over-the-counter prescriptions of self-medication. And 11.5% of Kenyans go seek healthcare in other facilities. That's the mission hospitals or the private clinics around where they live. Now, the value of health insurance, or the idea of having health insurance, is to avoid catastrophic health spending. And catastrophic health spending is defined as healthcare payments that are made that are so large compared to the household's budget that this expenditure disrupts the living standard of that household when they make that payment. Now, thousands of Kenyans, as you may be aware, or you may be a victim of, have been rendered poor, or they've gone into poverty from healthcare spending that has been catastrophic and hasn't been manageable from a family or from a household point of view. And now with me today to discuss this issue of healthcare expenditure is Catherine Karori. Catherine Karori is the General Manager of medical business at the Jubilee Insurance. And Dr. Abdi Mohammed. Dr. Mohammed is the Chair of the Kenya Association of Private Hospitals. Now, ladies and gentlemen, first of all, thank you very much for making it this morning to discuss this topic. As you know, it has been very dicey, it has been very emotive for most Kenyans. So I'll come to you to ask you why healthcare is expensive. And before we get to that, I'd want just to listen or to hear what Kenyans are saying about healthcare, because we went out on the streets and asked them if they agree with the 4 times per year outpatient limit by NHIF. And we'll just take a listen to what some of these Kenyans that we met had to say about that limit.
If there's terminal diseases, maybe someone has it, and it's mandatory that he has the NHIF card, he must be going through it. So what does it help him? If he goes 4 times, then the other times he sleeps in those, he'll just die. Yeah.
Story pia kusema ati it's 4 times, man. I mean, like, we are paying money. It's not for free. And when you're paying, you want to go to hospital at any time, at any given time when you're falling sick, because also you cannot dictate how many times utakuwa sick. So I don't think 4 times itakuwa ni kitu poa.
I'll use my NHIF card just once. Na huwa nalipa kila siku. So sasa vile wanasema mambo ya kulipa kugharamikia mambo ya matibabu just 4 times a year, kabisa hii ni kitu yenye heleweki, sababu for example there is a person who has been paying the NHIF since it was introduced na hajaitumia hata siku hata moja. So wakati unasema watu walipe watumie NHIF just 4 times a year, something which can't work.
Okay, as we've heard those Kenyans say and what others on social media said when that announcement was made is that 4 times a year is not tenable. Now I'll start with you, Catherine. This figure of 4 must have come from somewhere. Could you shed some light on why 4?
Yeah, it's interesting because I think this becomes the interesting number. Why? And I'll take you back because if you look at WHO standards, the standard is that any one person will seek healthcare at least an average of 4 times in a year. Now, 4 is an average because there are those who then will seek treatment many more times, and there are those who will never even seek treatment. So it's really more or less a WHO benchmark where we are saying that on average somebody will seek treatment 4 times in a year. Mm-hmm. Now, the issue about capping to the 4 limits, I know is very controversial, but I think, and I'm saying that because NHIF is a public insurer, and now on the other hand, I'm a private insurer. Mm-hmm. The challenge that they may be facing, and we are also facing, if I could speak for the private healthcare insurers, is that there seems to be a misalignment of stakeholders. So as far as the service providers are concerned, they look at insurance as a cash cow. So they want to be able to exploit as much as possible, and very unnecessarily in some cases. Mm-hmm. So you're looking at people who go to the hospital and the doctor is saying, come again, and come in for very unnecessary treatment. Some of them, and if you look at the database of the most common ailments in this country for outpatient care, that's respiratory tract infections. Mm-hmm. So you have people also from the patients also who probably feel entitled or probably say, you know, I have insurance, it's okay, let me just go to the hospital instead of remedying at home. So there are many ways in which we can be able to keep that average of 4. But there seems to be a misalignment of stakeholders whereby the doctors want you to use as much as possible. Mm-hmm. I met somebody who the other day said they went to the doctor and the doctor told them, if you don't come and use this cover, the money will just go back to the insurers. And you also have patients who feel this is a debit card and they want to exploit it. So when the World Health Organization sit down and say an average of 4 is reasonable, it is because genuinely, children may use a bit more, the elderly may use a bit more who have chronic conditions, but ideally an average of 4 is not something from the skies. It's actually a statistics that's well proven. Even in our books, we look at about 4.325 visits per person per year. So it's a legitimate number.
Okay. Dr. Abdi?
Thank you. The challenge is in a position, in a hard place. As you can hear, the private insurance are saying doctors want you to use more. And on the other day, when I supported NHIF for them to cap the visits 4 times, the public was saying, you're not fair to us. So you don't know which side you would push for. But the truth of the matter is for NHIF, as you clearly defined catastrophic health spending, the intention is to focus more on the inpatient. And that is what pushes people into poverty. Rarely would you hear someone calling you for Harambee because they want to go and see a doctor as an outpatient, or they want to go to chemist to buy medicine. But when someone needs dialysis or surgery, you will find cards for Harambees. So what the public need to understand is between inpatient and outpatient, where do you want to be helped more? And if you say you want to be helped in everything, then the question arises, how much are you willing to pay as a premium? So if you want to increase the premium, it's a challenge. Someone says, I can't even afford it. But if NHIF wants to use the little premium that you give them to cover for you where you need it most, and at the time you will need it most, you have another noise. And they did not say that is for the general outpatient. They said for chronic conditions, yes, we understand. If you are diabetic, you need follow-up. 4 is not enough. And they said they will come up with packages that will cater for the chronic conditions, separate. The 4 is talking about the normal cough and cold, the flu, diarrhea, things that might not happen. And that's what they are saying. We want to limit it to 4 so that we have more money for inpatient services.
Okay. And talking of that number of 4,
yes.
to limit outpatient healthcare seeking and focus on inpatient or the heavier burden, and we then shifting from primary preventive care to secondary care, as in, are we not shifting from preventing people from getting ill and needing that extra or a lot of money in spending on health other than preventing them from getting sick in the first place? Because literally it's like saying, limiting to 4 is like saying you can get sick, you can do whatever it is you want, but when you get sick and we need admission, we can cover you. But if you need to do preventive care, we are not able to cover you.
What we need to understand is, for prevention, it's an individual responsibility. So if you go to the washroom and you decide not to wash your hands, definitely you will get diarrhea, you will get cholera. That one starts with you. There is no way you can legislate that one, or you can decide and say, keep falling sick and we will pay every time you need to go to a hospital. That's not an answer. So the answer of prevention cuts across individual responsibility, county responsibility, national government responsibility, provision of water, sanitation, personal hygiene. Those things are things that are collective. What NHIF is talking about, it's in the event that you will need, and I will give you an example. If someone needs today dialysis care in this country, NHIF will cater 100% for 2 sessions per week. And if you say you will pay out of your pocket, roughly it will cost you 100,000 shilling. So how many families have that disposable income of 100,000 shilling per month? How many people can afford that much? Very few. Very few can actually pay 100,000 comfortably. And that's just the dialysis alone. There are many other complications that will arise with that condition. So what NHIF or any other insurance are saying is, let's take care of you when you really need us most. And the challenge with healthcare is consumed mostly by the extreme ages, children and the elderly. The young guys who are healthy, like you and me, rarely would want to go. I haven't gone to any hospital the whole of this year, and I don't hope so. So meaning, we are paying for people who might need these services, and when they need it, and we are the only people who are productive. You see, the 2 extremes are unproductive as well. They can't help you. There's no income your baby will generate or your elderly father will generate. So that's what we need to understand. For prevention, it's personal responsibility. You are the one who is supposed to find a way of going seeking, doing mammogram, doing pap smear. So those and the normal primary health care, you are supposed to take care as you wish. Okay. So that's the gist of the insurance.
I think I would like to add to say that some of the challenges we are dealing with today is that when you look at the population, and you said it earlier, about 22% of this country is insured, with 4% being in private healthcare, the other proportion being in, formal sector, which is the mandatory contributions from employer and employee, and the other being the informal sector. The one thing that is quite obvious when you listen to that public and, the reactions that have just been going on is really about lack of education. And I agree with Daktari when he says that people need to understand that they are actually their first-line insurer. And the issue of health insurance is really to be able to come in and support you when you need it most, not when you can be able to manage and have preventative actions and measures for yourself. So this is a country that, from where NHIF came from, which was a very basic cover in private healthcare. It just basically took care of bed rebates, to a cover that is so comprehensive today when you talk about dialysis, when you talk about chemo, when you talk about so many procedures and surgical packages that they've actually introduced. And the public feels feels very like, you know, you should be doing more. But the part they're also missing is, what is my role and responsibility in all of this? So I think there's really a whole issue about education, which we find ourselves also in, where members feel that, you know, when I'm ill, I should just be able to run to the hospital. If I'm ill today, I take all the 4 children, say, for example, just because one of us fell ill. So and he's right, because how much then are we willing to pay? And the principle of insurance is really about equity. And that's where the government comes in. They want to be able to agree with all stakeholders and say, this is the baseline. This is good care. Anything above which then you take care of it, or you pay whatever else you want to have, whether it's with you know, an elite health, private local health insurance, or international. So I think we have a very a public that we need to educate more, so that they do not see themselves as being very entitled and demanding. They need to know 4 is a universal average. What do I need to do with myself and my family to be able to take care of our health, and then appreciate that when it is catastrophic and most needed, that the insurance can be able to come in. Yeah.
Okay. And there are some issues you have raised, which I think I'd like us to do just a follow-up on them, on the usage of the health cover. Yes. But before we get to that, we also had time to also talk to the public and find out if they use their NHIF cards, if they use any of the insurance covers that they have. And let's just listen to what they had to say.
I've never used it. I didn't this idea because mostly nikienda kutibiwa naambiwa I cannot use it simply because, first of all, I'm working for which company? No. I have to be a civil servant or nitumie and no. Some hospitals wanakuambia hivyo. You have to be a civil servant or uende utumie kadi yako.
Hii mambo ya NHIF imekuwa inasumbua watu sana. Mtu akienda hospitali amekonjeka, alikuwa analipa, hakuwa ameambiwa masharti ako namna gani. Mwanzo hana pesa hata na chochote, hakujua kama mgonjwa atakuwa, anaambiwa atoe pesa kidogo ndio mgonjwa wake aweze kufunguliwa faili katika hospitali. Hayo mambo hayakuwa yamehusishwa katika mambo yale walikuwa watu wameambiwa kabla hawajalipa.
Wananchi wa Kenya wanatoa pesa zao wanaweka katika hazina ya NHIF. Alafu wakienda hospitali unakuwa limited ati unaenda mara 4 kwa mwaka. Na saa hiyo hawasemi yule ambaye naye hajaenda hospitali arudishiwe pesa yake. If they are fair, inafaa kuwa namna hiyo. Kama wewe unjaenda hospitali na mwaka umeisha, unarudishiwa pesa yako. Yule ambaye ameenda hospitali, basi huyo atengenezwa hata kama akienda mara 10. Kwa sababu tayari pesa yake iko pale ndani. Na ni mzuri pia wawe wakijua hivi. The concept ya National Hospital Insurance Fund ilikuwa ni merry go round, ambapo sisi sote tunatoa pesa, lakini sio wote wanaenda hospitali. Wanafaa wanjue hivyo.
Kama mimi nimelipa karibu miaka 10 na mimi hata sijaenda hospitali, sio pesa inaendelea kuhudumia wale wengine, iwasaidie. Kwa maana ukiona mtu anagonjeka sio mapenzi yake. Kwa hivyo ningeomba serikali, mtu hata kama anagonjeka mara 100, kwa maana ugonjwa si mtu anapenda, inakuja automatic. Kwa hivyo ningeomba mtu hao akitengenezwa mpaka siku ile atapona au siku ile ataenda kwa kafuri.
So, and I'd like to pick from that last gentleman who said somebody should access care for as many times as need be. And earlier on you'd said that sometimes doctors give unnecessary reviews or people go unnecessarily. Well, when do you know that it's unnecessary? From a doctor's point of view, you may not know that it's an unnecessary visit because you need to review your patient and see if they're making progress or not. So from an insurer point of view, when do you tell that this is an unnecessary visit?
Well, first of all, I have very good reaction, which tells you that there is really a gap as far as public education is concerned. I think there's one guy there who said that if I don't use that money, then it should be refunded to me. And first of all, one of the things that Kenyans are misunderstanding is that insurance is really about pooling of risk. It's about pooling the little money you can get, and then one or those 2 people fall ill, then they are able to use their cover. So coming back to your question in terms of how do you know what what is unnecessary. I think it's also an issue, and I'll let Dr. Abdi to talk about it a bit more, but it's also an issue of regulation. And there's something called treatment protocols and guidelines as to how to be able to treat certain conditions. And that is what, we find a challenge in the private healthcare industry, where we find that there really isn't proper policing or guidelines and adoption of proper best practices in how to be able to manage a condition. One person has one way in which they want to treat malaria, or one hospital. One doctor has a way in which they want to administer certain drugs. One doctor, we are dealing right now, and I think this is an issue that we also saw on NHIF raising in the dailies, saying that the cesarean section in this country has moved to the rate of 40%. And we are dealing with 40%. Yet WHO and world statistics are talking about 15 to 19%. So I think there's a whole issue about the whole ecosystem, being able to define what are the treatment approaches, what are the protocols, what are the best practices, and who is policing that, who is monitoring to say that these service providers or these doctors are in it for monetary gain and are not in adherence to best practices. So we do not want to come in as private healthcare, and then I believe NHIF does not want to come in and police and tell the doctor what to give, how many visits. That's not our business. It needs to be an industry that is self-regulating itself to be able to say that at the end of the day, we have a population of 44 million people who are either accessing healthcare through NHIF, private healthcare, or through the government taxations, and we need equity. So how do we distribute those very limited resources to be able to ensure that everybody gets decent coverage and decent health treatment, and make sure that it is not being exploited or being wasted? Things like even drugs, we've been talking about it as Jubilee Insurance, and we are saying, look at the ratios of branded to generic drugs. 80% of the drugs dispensed in this country are brands. In the Western markets, South Africa, Japan, they are lobbying for 80% branded generics. So it's this kitty that just needs to be managed well, and the private healthcare service providers to understand that at the end of the day, healthcare costs need financing, and there's only so much limited resource and how much we can distribute to the public and the private sector.
Okay. Dr. Abdi, and doctors prescribing unnecessary visits, unnecessary tests that are making just healthcare unaffordable?
I wouldn't say so, because the issue arises with private insurances. When they limit who should see their patients, then they should carry the cross with whatever that comes from that prescriber, because Jubilee will tell you only Dr. Mercy will see our patients. So if Dr. Mercy decides that she will exploit Jubilee, it's between Jubilee and Dr. Mercy who has decided to collude. So that is, to me, I wouldn't feel any sorry for the private insurance. NHIF, on the other hand, has tried to
But in that case, the person who loses is the patient, the person seeking care, because in a short span of time, they will have exhausted their limits.
And you see, that's now where the patient education and where the private insurance need to expand their service providers and pre-negotiate those packages that they would want to have for their patients. But if you give a limit and you just say it's 1 million outpatient cover, and then you say it's only Dr. Mercy who can see you, then if Dr. Mercy decides I will consume the whole 1 million, that is something that they need internal processes that they need to address. NHIF, on the other hand, decided to come up with the capitation model. And also they came up with the 4 visits which people are refusing, which was a capped per visit limitation, such that the provider is told, we will only pay you this much per visit this person comes. And the person is given to be responsible that you only have 4. Use when you need it. Don't go anytime. But you see, with the private insurance, you are given an amount. And then you are told, visit as you wish. And the provider is told, you can bill even 10,000, 20,000 per visit. So you see, those ones have no controls. And that's where NHIF was coming in, trying to put controls that it's not about the money, and individually, it's not for you to just walk into a mall, then when you get out, you say, I have a cover, let me just see the doctor. It should be a necessity, and that's the essence. I will give you an example of the car insurance. Rarely, you insure your car, a new car, for, let's say, 2, 3, 4 million. At the end of the year, you don't rush and say, I haven't used my 3, 4 million, let me crash my car. You don't. Why should it be the same for health insurance? Why should you say, I am remaining with 200,000, let me go and use it? It was not meant that way. It was meant you use it when you need it. And that is the essence.
You had a reaction on that?
Yes, I do have a reaction because I think, again, and the essence at the end of the day is that we have a common problem, Daktari.
Yes.
We have a population of 44, 45 million Kenyans that we need to ensure can access health care. So I think we need to be speaking the same language more often than having points of differentiation. Now, as far as the service provider panel is concerned, the insurers accredit service providers. Now, let's also admit that in this country, there's a very limited. So the other day I was reading it up, and I'm seeing that the health practitioners, nurses, clinical officers, you know, whoever, are about not more than 200,000 in this country. Doctors about 10,000. So already, even in our accreditation process, we are really handicapped to the extent that the number of service providers we can onboard into the panel is already so limited. So it's not that we are working with Dr. Mercy Korir and saying, you will see our patients. The panel is diverse and as inclusive as possible. But I think the disconnect we continue to have is that the service providers, the doctors, the hospitals, by the time they, to take for example the doctors, there really isn't probably a cost that handles or a unit that handles healthcare financing or with specific reference to insurance. So they come in and they, as far as they are concerned, they don't have an understanding of financial implication as far as this cost is concerned. They know the patient is here. Do they have a card insurance? Yes, great, fine, let's treat. So I think the issues that we are trying to raise here, and this is the issue that's plaguing NHIF, because the private healthcare may not institute a capitation, but they are instituting things like co-payments, where a member goes to the hospital and has to pay a part of the bill, because then you have to think about, do I really need the care in the first place? So there are various gatekeeping mechanisms. Co-pay is one of them, and capitation is one of them. NHIF's idea of having an average of 4 or limiting to 4 is one of them. Why? Because there is continuously a disconnect between the public and the service providers and the insurers about the common objective we're trying to achieve. And until we are aligned, and until we can have proper regulation as well, and various stakeholders self-regulating themselves, if it is the service providers, they need to come back and sit to the table and say, how do we make this penny stretch for the long haul for this public? And the insurers need to be able to see how can we make our business more efficient as far as our administration of it, to be able to have a penny go a long way. And the public to be able to say, how do I use it when I need it? And those are the real issues that we are dealing with. Because already, you and me know this system has already a very limited panel for members to access care.
True.
Doctor, I'll just hold on to that thought. Yes. And also, when I come back, yes, I want the two of you to say what is the best practice then, because NHIF is seemingly plagued with its own issues. The yes, private insurance yes, is plagued with its own issues. Yet we know there are countries which have actually achieved coverage yes, for its citizens, and they are doing relatively well. But before we come to that, I want us to just listen to Francis Atwoli, the Court Secretary General, what he had to say about the NHIF limit of 4 visits when it was announced, and just prior to the CS Health, Dr. Cleopa Mailu suspending it. So let's just take a listen to Francis Atwoli.
National Hospital Insurance Fund will continue as it has been in the past to offer both outpatient and inpatient services just the way they have been doing. Formerly, if you are, they had designated various health centers per person or for a person where you are supposed to go. But this time they had opened up in that resolution. Apart from the 4 visits per year, those were the areas that were a little bit contentious. We had not consulted, and that's what we were consulting here.
Okay. Dr. Abdi, I'll start with you. NHIF has issues, private insurance has issues. No one really seems to be offering the best value for money as it is now. What are other countries doing that is so different that they've been able to achieve relative coverage, good coverage of healthcare for its citizens? Take a look at Canada, the UK, they're offering services. So what have they done differently that we are not doing?
To say that NHIF is not giving value for money is far from the truth. The reality is you can't pay 500 shilling and get all those benefits that you are getting. No one in the world, even Canada, UK, can't give you the services NHIF is giving you for the 500 shilling. That's the reality. But what we need to understand is also it's the type of premiums that we are all paying. Because you see, there is no limitless pot that the insurances will be picking that money from. And the other thing is we must get a wider coverage than the 20 million that we are talking about, meaning almost everyone must participate. At the moment, for NHIF, what they are getting is the mandatory people who are employed and people who need to use it, which introduces adverse selection. So meaning, I need dialysis. I didn't have NHIF before. I never used to contribute. But because now I want to use it, and then that's when I contribute. I'm young. I don't need any issues. I don't have any health issues. I don't pay. And as I have told you, the health consumption is at the extreme ends, elderly and the young children. So we need, even when you are healthy and you are young, you need to contribute. That's what we need to understand, that everyone must contribute in one way or in another. That way, then they have a bigger pool of money to give better services and procure more from from the providers. Without that, then we are just limited. It's the same way you are limited when you are told go and seek health service from your pocket. You see, individually, if today you are told you need any care, yes, pay from your pocket. You have limitations. There are certain hospitals you will never step or go anywhere near them because you know you can't afford. But you will go to certain hospitals. It's the same way for the insurance. They have limits as well. There's so much that they can give depending on so much you are willing to contribute. Okay. And that's what the public need to understand.
Catherine?
I think I want to appreciate the fact that, universal health care coverage being, a government mandate and where they are at today, and I agree with Daktari, is really a good step in the right direction. And how some of these models have evolved. Let's not imagine that the US, that's North America, Europe, or even South Africa or Asia, came to where they are today. It's taken a lot of reform. It's taken a lot of change management from all stakeholders. It's taken a lot of reviewing of technology in terms of how do we diagnose right the first time, so that kitty that is being used 5-6 times, as the users are complaining that sometimes they need access, up to 10 times, can be reduced with first-time diagnosis. So it's a lot of issues where the governments in those markets have evolved and they've had a lot of reform. So we have a step in the right direction. One of the things that you find in those markets is that healthcare or some form of health insurance is mandatory. Mm-hmm. So do we need to look at that and make sure that it's mandatory? Because today, Dr. is right when he says that it's what we call in our industry anti-selection. So we are dealing with a lot of people who only come to buy insurance, even in private healthcare, except for the employer, contributions and buying for them insurance. Most of them will only come in when they are ill, or those who are educated. So you're right, there's a lot of people who will enjoy, and young people will enjoy their drinks over the weekends. But that amount they are spending over the weekend or in 1 month is equivalent to how much they would pay to NHIF. So just educating the public and telling them this needs to be mandatory is going to reach us there. Exactly what I said there, that, just before, is that the reform is a whole ecosystem. it also needs to look at, it's not enough for users to keep contributing and contributing. How else can we make the whole system efficient? How else can we make sure that cost of treatment is affordable? And I'll probably just go back to the same conversation. Why are we dispensing so many brands versus generics? How can we change that ratio and make sure that instead of using 5,000 in some key hospitals per visit, or 4,000 or 3,000, that cost can be greatly reduced? How do we also educate the public on wellness? And that's what you have found successful in other markets. The focus stops being, how do I draw from this kitty, to how do we keep you healthy? And how do I keep you out of hospital? Because today in certain markets, that's how the service providers are compensated and paid. We audit you in Europe, say for example, or North America, you're paid based on value health outcomes. So they want to be able to say, how much better do you have better recovery rates? How much do you have complications, hospital infections, readmission rates because surgeries went wrong? So it's a whole thing to look at. Let's not just look at how do we draw from it. Let's look at when it's being drawn, is it efficient? And are we drawing from it with wise thinking and spending? Can we reduce the cesarean section rates? Can we reduce... I know NHIF doesn't cover optical, but from our perspective, how do we define what is cosmetic versus basic healthcare? So I think it's a whole big thing, and how they've succeeded is really about reform and reviewing every angle of the ecosystem.
Okay. And also, the other thing is to keep in mind is most of our inputs in healthcare are imported into the country.
Yes.
Very few are locally manufactured. So meaning, if the government also taxes heavily, it doesn't help. So that when you are buying one machine and 50% of it is on tax, so meaning there will be more money that's needed to recover the cost of your setup. So that also needs to be addressed as well, the cost of inputs. The other cost is health, the personnel, which is easily to handle. But things that are out of our hand need to be addressed. And the public also need to understand, out-of-pocket is not sustainable.
Yeah.
Prepayment for health is the solution. And prepayment will help pooling of risks. That's the essence. Out-of-pocket, not sustainable.
Okay, and talking of health costs of healthcare, where, okay, the private providers, where you are the chair of, cost from provision of commodities, supplies, and whatnot, and they cap and they put margins. Yes. When you compare to the public sector, the public sector will be less. Then now, if you take an example of a cesarean section, which you have kept mentioning, the same procedure done in a public hospital will cost way less than the same procedure in a private hospital. Yet NHIF will pay differently, and at the end of the day, there seems to be support for the private healthcare, and the public healthcare becomes unsustainable. So, Dr. Abdi, I want your comment on that. As your final concluding comment.
Yes, you contradicted yourself. NHIF, as you said clearly, are paying differently because different providers, it costs them differently. So you see, NHIF also has to be fair to see that, yes, it costs you 1 shilling, then we can pay you 2 shilling. But it costs her 5 shilling, it's only fair we pay her 6 shilling. There's no way we can pay you. That's number one. Number two, let me just clear it so that you get me correctly. If today we decide everyone should go to public hospitals, do we have the capacity? 50% of Kenyans seek healthcare in the private sector. Sometimes not out of choice. In some places, there's no public facility. If you go to northern Kenya, all you will find are mission hospitals, mission dispensaries, mission health centers. So meaning, those people will not have an option. The only option that they have is the alternative. And all of us cannot fit in the public sector. So NHIF also have to consider the payer, who is you and me, who is contributing, to give them choice that go to X, we will pay. Go to Y, we will pay. You have the liberty. Dialysis has been set up almost in every public hospital with this managed equipment. But you will still find patients going to private facilities. And if you tell them, no, only go to this place, they will tell you, no, I have a choice and I have a right where I want to go. That is the challenge. So you, in one way, it's good to say, yes, we want to limit the cost, but you also have to give people the option on what they want to do and how they want to do it.
Okay, thank you. Catherine, as your closing comments?
Yeah, I think, well, when you look at it at the end of the day, we need more stakeholders on the table. I think from a private healthcare perspective, we need to get more stakeholders, the ministry more involved. The health agenda is a big agenda, but I think we are not focusing on it appropriately to be able to see how best we can ensure that there is long-term sustainability. We are bringing in quick and short-term solutions, but you know, as he's saying, the whole investment in public and private needs to be looked into, and the regulation as to how that is being done, because health inflation is the biggest challenge of private healthcare today, and the same for NHIF. And, you know, that's not regulated. That's not monitored. Nobody is talking about should service providers increase the cost of treatment from one year to another by 15%. How sustainable is that? It does not matter how much premium you pay, whether under NHIF or private healthcare, you will not have that cover in the next 5-10 years. So I think this conversation, there's something, a good conversation going on the platform of NHIF, 4 visits. I think we need to come to the table now and ask how, if it is 4 visits, and indeed WHO says a person will visit the hospital about 4 times, our database as Jubilee Insurance shows about 4.35. How do we make that sustainable? So I think it's looking at that whole model and seeing that it's sustainable for all.
Okay. Thank you very much for your time this morning.
Thank you.
We have been talking to Catherine Karori, who's the General Manager of Medical Business at the Jubilee Insurance, and Dr. Abdi Mohamed, who's the Chair of the Kenya Association of Private Hospitals. And the topic today, we are talking about health insurance and health coverage, provision of health through the insurance, both NHIF and private insurance in Kenya. Join me again next Wednesday for different discussions on issues that affect your health. I'm Dr. Masi Korir, and I wish you a very good day.